طبعا جميعا وان شاء الله يا رب. طبعا ان شاء الله يا رب هذه طبعا اللي هو المجموعه او حتى طبعا اللي هو الجراند راوند يضيف طبعا او حتى يعمل على تبادل خبرات، طبعا يقوي اللي عندنا الشباب ان شاء الله، شباب البورد ان شاء الله، صبايا البورد ان شاء الله. انا
يا رب.
بتشكركم جميعا.
أهلا وسهلا بك.
الله يحفظك
يعني
دكتور أحمد.
الله يسلمك يا رب.
ربنا يبارك فيك. معانا كمان دكتور أحمد متولي من تريبل اتش، المؤسسة الراعية لهذه الأكتيفيتي اللي هي دكتور تو دكتور سبورت. أهلا وسهلا يا دكتور أحمد.
أهلا وسهلا يا دكتور، أهلا وسهلا بحضرتك.
أنا دكتور أحمد.
طيب
زي حضرتك يا دكتور أحمد.
الحمد لله. الدكتور ياسر، هم الشباب الزملاء من القطاع دخلوا موجودين يعني مع حضرتك، ولا هيدخلوا بشكل منفصل ولا ايه؟
دكتوره سحر، بس خلينا اشوفه معه.
طيب تمام خلاص ماشي.
طيب بقى.
طيب أهلا وسهلا بحضراتكم في أول جراند راوند للسايكاتري اللي هو بالتعاون بين مؤسسة تريبل اتش ووزارة الصحة الفلسطينية. حضراتكم مشرفينا، ويعني في مجموعة من السايكاتريست من أماكن مختلفة، بالإضافة لزملائنا السايكاتريست في القطاع. أنا هدي دلوقتي الميكروفون للدكتور مصطفى يبدأ المحاضرة بتاعته لحد ما دكتور عبد الله يقدروا يلحقوا بينا إن شاء الله. اتفضل يا دكتور مصطفى.
شكرا دكتور صح. بسم الله الرحمن الرحيم. متشكر جدا الفرصة الجميلة دي، يعني من تريبل اتش ومن دكتورة سحر هانم. يا رب نكون إن شاء الله بإذن الله يعني قادر يعني نقدم حاجة لأهالينا وإخواتنا. فأنا اسمي مصطفى أحمد بسطاوي، وأنا استشاري طب نفسي في إنجلترا، جنرال أدلت. فالنهارده هي بس المحاضرة عن يعني زي introduction كده للسايكاتريك اسسمنت كبداية يعني للكلام. أنا بس بحاول شيء. أيوه. أنا بس مش أنا زوم بالنسبة لي حاجة جديدة يعني. بسم الله الرحمن الرحيم. أوكي يس.
شير عايزين الشير. حضرتك شغال من على ديسكتوب مش كده؟
من على ديسكتوب. أتمنى إنكم تكونوا شايفين
خلاص دخلت
السلايدز.
وصلت
تمام
دكتور.
تمام. وأنا هعملها بس تمام. شايفينها كده كويس؟
شايفينها كده كويس.
طيب
حضرتك
الحمد
ممكن
لله
بس
يعني.
تكبرها، ممكن تكبرها من عندك.
أنا كبرتها دلوقتي، أنا خليتها سكرين فول سكرين.
لسه
طيب هي عن psychiatric assessment. هي actually بصراحة عشان بس الوقت كان قصير، فأنا يعني depicted from slides presented by junior دكتور حسن مالك. الكلام ده كان back in 2022. أنا عملت فيها changes بس يعني إحقاقا للحق يعني. فهو يعني احنا covering سريعا كده النهاردة. هي السايكايتريك assessment اللي احنا بنعمله مع العيانين. هو يعني starting by psychiatric history, mental state examination like any other medical field, medical specialty, followed by risk assessment, formulation of all the data we have, then going to provisional diagnosis and treatment planning. For quick concepts, we work in like a holistic approach, including biological, psychological, and social model. So you will sense this in the assessment that we tend to check on these three aspects of human life in our patients. Descriptive psychopathology, objective description of abnormal state of mind, including preconceived
ممكن
ideas or things.
دكتور مصطفى معذرة ممكن بس حضرتك تغير السلايد يعني حاولت احنا مش ماشيين معاك في السلايدز.
تمام طيب حاضر شكرا. طيب انتوا شايفين كده what are we
بالظبط
covering؟
ايوه
يس.
تمام. شايفينه كفول سكرين ولا شايفينه
لا للاسف لا، شايفينه كسلايدز بس.
هو
سلايدز.
معلش هو طيب يعني
حضرتك من تحت خالص.
من تحت فول
من
هي
تحت،
سكرين.
مشكلة
أيوة،
لما
فول
عملت لما عملت
جرب
فول سكرين
جرب هتيجي ان شاء الله.
هو كده فول سكرين. انا كده تشينجينج. انتوا شايفين
لا
هي كده
السلايد
ماشي خلاص ماشي
مفيش مشكلة شغال تمام.
شغال كويس خالص.
سايكاتريك
ف
هيستوري منتال ستيت اكزامينيشن تمام.
تمام.
ماشي يا دكتور اتفضل.
فوصلنا للديسكريبتيف psychopathology، دي السلايد اللي انا واقف عليها دلوقتي. objective description of abnormal state of mind, avoiding preconceived ideas or theories, and limited to description of conscious experiences and observable behavior. دي القدرة على ان احنا او skills of descriptive psychopathology is a fundamental professional skill for any psychiatrist, which make it يعني support the psychiatrist to elicit, identify, interpret symptoms of psychiatric disorders. Quick concept as regard the interview skills.
change slides دكتور.
طب انا عملت change.
لا واقفة عند
عند 2.
عند رقم 2
ما هي نفس المشكلة، يبقى أنا هضطر إن أنا ألغي
طب ممكن حضرتك بقى خلاص يعني من السايدز اللي هو السلايد
maybe.
انت حضرتك بالظبط خلينا كده ماشيين بقى يعني ايوه
تمام.
حضرتك ماشي كده تمام.
تمام.
ماشي.
فإحنا دلوقتي عن أنا يعني كويك كونسبت برضو عن interview skills. من يعني among the skills إن إحنا to set up the environment, ensure privacy and confidentiality when we are discussing with the patient. Empathy is very important, either verbally and body language. Listen, the most important thing. Actually, we have even to resist the urge to stop the patient or to interrupt the patient to ask a question. We better allow the patient to explain and express themselves. It's important that we summarize our understandings to the patient just to check that we understood the patient, we understood what the patient, what message the patient wants to deliver. We analyze one psychopathology in full analysis at a time. We start by open questions and then we narrow down. Avoid double questioning, which is another thing that it is like an urge because of the pressure of time that we sometimes make this mistake. And the most important thing is whenever we are analyzing any psychopathology to assess the impact on the social function of the patient, on the occupational function of the patient, on the personal life as well. Structure of psychiatric history, basic information, presenting complaint or history of presenting complaint, or sometimes we call it history of presenting illness, past psychiatric history and past medical history of the patient, alcohol and illicit substance history, family history, personal history, forensic history, pre-morbid personality. So basic information, it's just basic information like name of the patient, date of birth, age, unique number, unique service number, marital state, address, next of kin identifiers, as the carers and their contacts, route of referrals, current legal status according to the local legislations. As an example, Mr. A is as an example of basic information, Mr. A, 29 years old, single man, brought to emergency department by mom due to worsening bizarre behavior, suspiciousness, and hearing voices. A history obtained from patient and his mother. Reliability of the history was limited by paranoia and thought disorder. Presenting complaint, number and brief description of presenting complaint. What is the most troublesome symptom, and usually it is usually it is in the patient own words. So an example, he presents with hearing voices, persecutory beliefs, social withdrawal, poor sleep, reduced oral intake, and deteriorating self-care. And then we will start to analyze the complaint through the history of present complaint. List of the symptoms with the onset, duration, fluctuation of each, triggers behind the symptoms, and analysis of beliefs and sensation, ABC and assessment for behaviors, antecedent, what happened before the behavior itself, what happened during the behavior, consequences, what happened after the behavior, how the patient react toward the behavior, which concern the carers or the patient, and again, impact on function, the temporal relationship between symptoms and any physical, psychological, or social problems. As a demonstration of history of present illness, over the past 3 months, Mr. A became increasingly withdrawn, anxious, suspicious of others, believed that neighbors spying on him through walls, and the people in the street are talking about him. Over the last 6 weeks, he has started hearing 2 male voices commenting on his actions, and at times telling him that he is being watched. He denies recognizing the voices, but say they are more frequent at night and when he is alone. Sleep has significantly reduced, often stay awake pacing around his room. He became increasingly isolated from family and friends, stopped going to work, neglected washing and eating properly. Mother reported that he has been speaking to himself, muttering under his breath, appearing preoccupied, also been seen covering the windows and unplugging devices because he believes he is being monitored. Denies any deliberate self-harm or suicide attempt, appear frightened and guarded, no clear history of elevated mood, increased energy or grandiosity, or increased goal-directed activity to suggest mania, no known recent traumatic events. Symptoms have progressed gradually and are causing marked function decline. So this is like a general description of how we manage history present illness or history of present complaint. And then in each and every disorder, we have more specified symptoms to ask about to reach a diagnosis of a specific disorder. Past psychiatric and medical history, like previous psychiatric diagnosis, previous similar episodes, previous treatments include admissions to psychiatric hospitals, include ACT, past medical history, chronic disease, especially heart disease, head trauma, neurological disease, thyroid gland disease, any supplementary deficiency, low vitamin B, low vitamin D, iron deficiency or anemia, all these things can affect the mood. And as an example of past psychiatric and medical history, he has no previous psychiatric admission or formal psychiatric diagnosis. He has not previously been under the care of mental health service. No history of self-harm or suicide attempt. His medical history is unremarkable. He takes no regular medication and has no known drug allergies. Family history, any history of mental illness in the family, including responses to treatment, any history of severe heart disease in the family. Why we focus on heart disease? Because most of our medication can prolong QTC interval. Some of our medication can increase heart rate, can increase blood pressure or drop blood pressure. So it's important to be aware of any heart disease in the family. Relationship with the family as well is important. As an example or demonstration, there is a family history of depression in our patient, a family history of depression in his mother, who was treated in primary care several years ago. Maternal uncle reportedly had a psychotic illness in his 20s. No known family history of bipolar disorder or suicide. Personal history. We try to literally, chase the patient even from before birth, perinatal information, complicated, if there is any history of complicated pregnancy or complicated labor, any history of admission to neonatal ICU, developmental milestones, childhood illness, childhood physical illness, and childhood memories. Either was there any adverses during childhood, trauma, abuse, bullying, education, and also again any bullying experience in education, sexual development, orientation, and practice, religion, beliefs, and practice, employment history, accommodation, relationship, caring responsibilities, finance. Why it is important to ask about personal history? Because we can, from the personal history, we can pick up predisposing factors for illness. We can pick up perpetuating factors and precipitating factors to the current presentation. I hope I'm not going so fast. So if you have any questions, please let me know.
كتير الدكتور مصطفى.
Okay, thank you. I'm aware that our colleagues are not with us at the moment. So,
they are not
yeah, so I'm just trying to, to complete it in case of they manage to join.
And
For
also
the
we are
records.
recording for the recording,
Okay.
and we'll upload
They
the
can
recording
catch
to
the
them.
record, yes. Good. So Mr. A was born, as an example of a personal history, Mr. A was born and raised in London. No reports of any complication during pregnancy, history of obstructed labor and use of tools, did not require neonatal ICU admission, normal developmental milestones, report traumatic childhood due to persistent emotional and physical abuse. He never received treatment for this, completed secondary education and began working in IT after college. Has been in steady employment until recently, when his symptoms began affecting his attendance and performance. He lives alone in rented accommodation, but remains in contact with his mother and sister, who are his main support. He is not currently in a relationship and has no children. No reported issues with finance, housing, although his mother is concerned that he may soon lose his job because of his deterioration in function. So this is an example of personal history. Alcohol and illicit substance misuse. We ask about any alcohol or illicit substance misuse, what the person has ever been using, the onset of the use, the current frequency, reason for the use, what the person find in this drug, previous attempts for abstinent, professional support was either did the patient seek professional support or not, any withdrawal symptoms related to the misuse, tolerance, previous overdose, impacts on social, occupational, mental health, and this for every and each illicit substance and psychoactive substance. So he drinks alcohol socially, approximately 4 to 6 units per week. He denies any binge drinking or dependence. He reports occasional cannabis use in past, but say he has not used any for several months. He denies cocaine, amphetamine, ketamine, opioid, or benzodiazepine use. He is a non-smoker. So this is how we elicit the alcohol and drug misuse. In again, this is a general adult psychiatric case. In cases with substance and alcohol misuse, as a primary complaint, we will have to explore more about the use of drugs. Forensic history, whether the person was charged with, or convicted or dismissed from any accusations related to aggression, violence, neglect of vulnerable adults or children, sexual inappropriateness, deception, exploitation, antisocial behaviors. In our case, there is no history of arrest, conviction, imprisonment, or violence. He has no known current legal problems. We also ask about pre-morbid personality. How would the person or the carer describe the patient before they became ill? Character traits: perfectionist, obsessional, isolated, impulsive, sensitive. Also check for being introvert or extrovert, being a believer, following a specific religion, believe, practicing religion or not. Pre-morbid personality before becoming, for our patient before becoming unwell, he was described as quiet, reliable, socially reserved. He was independent at work, independent in self-care, and had no previous personality difficulties. So for now, we have completed the history taking a part of the psychiatric assessment. Any questions or comments so far?
You denote about the medical history and previous medication. I think history.
Yes, in psychiatric and medical history, past psychiatric and medical history.
Yes.
So yeah, some schools just put them together and rather than separated.
Okay.
Is any specific consideration related to the condition in Gaza? While you are examining the patients, or
This is very important point.
yes,
because
yeah,
they
to be
are
honest,
in a PTSD,
Yes.
or we couldn't say PTSD, they are in a continuous trauma, they are affected, and maybe some symptoms are related to what they are exposed to.
yes, definitely, I do agree that now the psychiatrist in Gaza will have to use all the available skills including the awareness of the environment and what is going on. So this is like what I brought today is like the general baseline of practice, but definitely working in a war zone will require more skills, and definitely we'll have to focus on trauma related symptoms in any assessment.
Yes.
It can be discussed in the future with specific disorders.
Oh yes, yeah. So the the curriculum included stress-related disorders and post-traumatic
Yes,
stress disorder and acute stress reaction. So I think in we will find more details around more details related to
yes,
what the people are seeing in Gaza in in these disorders. Yeah.
yes,
I was reading an article, a study about people in Gaza after 1 year of the war, and there is confusion between PTSD symptoms and psychotic symptoms. Yeah. We can't, yeah, and the depression and the anxiety and the emotional dysregulation are the base for both.
Yes. Yeah, and yes, it is very common that the dissociative reactions related to or generated by trauma
Oh, yeah.
to be
yes,
misdiagnosed as psychotic
And
experiences.
derealization, depersonalization. Yeah.
Oh, yes,
Mm.
yeah, exactly, yeah, yeah. And this is why it is important as we will go to the mental state examination to uh, to analyze each and every psychopathology the patient comes with. So if the person reported hearing voices, we have to explore more about the voices and the understanding of the patient around the source of the voices, the impact of the voices on the patient, and from there we will be able to differentiate dissociative reactions from uh, true psychotic experiences.
yes, 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 Dr. Mustafa. It's excellent.
For me, as a trauma informed psychotherapist, not a psychiatrist, and for people in Gaza, if the people say I hear voices, it may be for me a survival strategy because they need to be so cautious about the voices of the quadcopter and the all things,
Oh,
and
yes.
so they became so sensitive in hearing and seeing, and so it is to detect any danger.
Yes, yeah, I can imagine. Hypervigilance is a very common, it's actually one of the triads of the post-traumatic
Post-traumatic.
diagnosis.
Mm.
And yeah, I feel for them that, and I know actually that when the noise of the quadricopter goes off, it is then when they are anxious because this means they will do something. There will be an attack, there will be a missile or an artillery or whatever. Um, so this background noise that we usually hear in all the videos from there is for them. I've seen people reporting that this for them it is actually a soothing noise because it means they should not expect an imminent attack. They are just
Relaxing,
serving
serving, yeah.
serving them. Yes,
Mm.
yeah.
Okay.
اوكي يا دكتور
Um,
مصطفى.
أعتقد
yes,
إن ده
I'm
أعتقد
sorry.
في إن إحنا محتاجين في الجزء ده يعني talk about hallucination, difference between hallucination in psychosis and hallucination in anxiety disorder.
مم.
لأن في السايكوباثولوجي في اختلاف كبير ما بينهم وبين بعض.
ان شاء الله. هو انا يعني طبعا انا بس يعني عشان انا ده عامل زي كده رود ماب.
بريف يس.
فانا فارد لغايه تريتمنت بلاننج. بس طبعا يعني طبعا يعني احنا شايف الكوريكولوم. احنا هنجيب ديس اوردر ولازم نشرحه ونتكلم فيه. اعتقد ان ساعتها ممكن بقى يعني in each and every disorder we can differentiate. يعني ممكن نتكلم على how to differentiate dissociation from psychosis, how to differentiate mood symptoms from psychosis. فانا
Yes.
هكمل سريعا.
اتفضل حضرتك.
المنتال ستيت examination, general appearance and behavior, speech, mood, perception, thought process, spanning content, form, control, and stream of thoughts, cognition, insight, and capacity. General appearance and behavior, description of how the patient looks, outfit of the patient, grooming and hygiene, appropriateness of the behavior during the interview, motor activities, either normal, slowed, or agitated, the rapport, the ability of the engagement of the patient with the psychiatrist. Then we go to speech, where we discuss the rate, the amount, the tone and volume of the speech. Is it spontaneous, and is it coherent? Is it relevant? Emotional expression. It's important to understand the difference between mood and affect. So affect is the objective part of the emotion, how the mood appears to the clinician, what emotions expressed in front of the clinician. It can range from flat, restricted, to normal, to labile affect. It's important to describe the amplitude of the expressed emotions, whether the expressed emotions are congruent or incongruent to what the patient, the ongoing thought process, and the diurnal variation in the mood. Thought content, thought process, starting by thought content. What thoughts that causing difficulties or struggle for the patient, the self-acceptance of the thoughts, egocentric or ego-dystonic, the source where the thoughts are coming from, either it is generated from self-generated or alien thoughts, conviction, how far is the patient or the person believes in these thoughts, the attitude, the resistant, whether the attitude of the patient toward the thoughts, and whether the person is resisting these thoughts or not, persistent thoughts or fleeting or intrusive, and the impact of the thoughts on the person's life. It's important to differentiate between different contents. So we have preoccupied ideas, we have overvalued ideas, obsessions, delusions. And what is the difference between them? And preoccupied ideas are more like an idea, a belief that the person is preoccupied with. The person include discussions about it in every or most of the day. It can be the preoccupied idea. It can be wrong. It can be right, but it's just something that preoccupy the mind of the patient. And it is not fixed. There is conviction, but it's still the patient or the person is accepting that there is possibility of being wrong. And then we go to the overvalid idea, which is similar to preoccupied ideas, but with a more emotional component related to it. And this increases the possibility that the patient act on these ideas. And there is the obsessions. Obsessions are intrusive, recurrent either thoughts or images or urges. It is characterized by being ego dystonic, unaccepted by the person, unwanted by the person, and causing distress and anxiety. The only way to get rid of it is to resign to compulsive acts. And the delusions, the false fixed beliefs, which are held with strong conviction. Usually the person is lacking any insight towards it, believing it is true, can be associated with emotional tone as well. The person does not the person does not consider these thoughts. I'm sorry.
Continue.
The person does not consider the thoughts to be wrong, and strongly resist to counter arguments. And so it is important to be able to differentiate between preoccupied ideas, overvalid ideas, obsessions, and delusions. So this is the thought content. Thought form is when we let the patient talk in free association for a few minutes and then assess whether there is coherence in his speech or not. Normally it should be linear, organized, and goal directed. There are things like thought blocking, circumstantiality, tangentiality, and circumstantiality, like going in circles, and at the end the patient or the person reach the target for the conversation. Tangentiality, even they do not reach it. Clang association, where there is incoherence due to focusing on linking words and sentences based on the tone rather than the meaning. And flights of ideas, where there's rapid movements from one thought to another. We also assess whether there is a lack of control of patient on his or her thoughts and the stream of the thoughts. So going to perception, here we are assessing if the patient has any unusual perception in any of the five sensations, like hearing, like vision, like touch, either crude touch or fine touch, tactile or proprioception, taste, smell. So it's important to identify what sensory modality, what sensory modality does the patient have this unusual sensation in? How often? When is it? When does it happen? Is it related to sleep? What usually trigger it? What reduces it? The explanation the patient gives to the experience, whether the patient has insight towards it or not. It's important to differentiate between illusion and hallucination. Um, uh, so hallucination is perception without even presence of any stimulus, and illusion is misinterpretation of already existing stimulus. Out-of-body reactions like derealization and depersonalization, which we see in very severe forms of any anxiety. Um, Cognition, assessment of cognition, the alertness of the person. Well, we rarely need to use the Glasgow glaucoma scale, but it can be useful. Orientation to time and place and person, the ability of the person to concentrate and maintain attention using the serial 7, so asking the person to subtract 7 from 100, and we usually go for 3 to 5 sevens. Assessing short-term memory and long-term memory, abstract reasoning, what similarities between apple and pear, the ability of the judgment, like asking the patient any question regarding their judgment. If you found an envelope with an address and postal stamp on the sidewalk, what would you do? And in every area we can, I mean, every part of the world we can always, like the psychiatrist can formulate a judgment question which is suitable to the culture. And then we assess the insight. Is the person acknowledge that there is an issue or not? And is this acknowledgement include the understanding that there will be need for treatment and need for professionals or not? And based on the outcome, I'm sorry, I didn't get this.
كمل حضرتك كمل. continue.
And based on this, we decide whether there is full insight to the 3 aspects, or there is partial insight, or there is no insight. And last part of the mental state examination is the assessment of the capacity. So it's important to know that capacity is a task specific. So we assess the capacity for a specific task. During psychiatric assessment, we assess capacity to decide about the mental health care plan. This is the main the task that we assess. Is the person in front of us capable of deciding about the mental health care plan, including where, as we mentioned in after a while, where to be treated, what medication, what intervention required or not. It's not a medical monopoly, which means any professionals with any professional like social worker, like mental health nurse, like any medical doctor, GP, should be able to perform the capacity assessment. It goes into 2 phases. First, or 2 questions. First, is there any mental illness or not? It doesn't have to be a disorder, fully diagnosed disorder. If there are symptoms, this can help us to go to the second question. If there is no mental illness, then the person will be assumed to have capacity by default. So if there is symptoms of mental illness, we will go to the second question, whether these symptoms are affecting the person's understanding of the task, or retaining information about the task, and or weighing the risk and benefit of the decisions related to the task, and or communicating ability to communicate the decision. Any questions so far?
It is clear about mental state examination as يعني global or not specific for many disorders يعني. Will be discussed later with specific disorder إن شاء الله.
Oh, yes, definitely. I do agree. I'm just I'm trying to enumerate the, you know, it's like a roadmap, a
Yes,
quick
yes,
roadmap. When it's like for any trainee. So I have finished my medical school, and now I'm going to be a psychiatrist, and I'm going to do a psychiatric assessment. So I'm just taking this trainee through the journey of
yes.
doing psychiatric assessment, including history taking, including
Mental state examination.
mental state examination,
Yes,
risk assessment, formulating, and putting a treatment plan. This is usually, this whole cycle usually completed within one sitting, or expected to be completed within 1 or 2 sessions in maximum by the psychiatrist. So it's like a roadmap. When psychiatrists sit down with a patient, what what steps do we do? What things we do during this interview?
it is very, very,
Definitely,
very,
there are more and more details within
yes,
every disorder to differentiate it from different disorders. Yeah, I do agree.
yes. You will be discuss about risk assessment later. No?
Oh, yes, yeah.
Yes, yes.
Would you like? It's up to you. I can.
So,
I mean, um, but I mean, I can do this on another day. The rest of the risk assessment, the formulation, treatment. It will be a short lecture in another day, or I can complete it today.
دكتور سحر
ايوه
آه، دكتور مصطفى يعني يكمل ولا
هيكمل
يكمل؟
هيكمل
اوكي اوكي.
So risk assessment, we assess risk of harm to the
Yes.
patient, to the self, to himself, risk harm from patients to other people, risk harm from other people to the patient. So risk of harm to other, like including violence or neglect, if the patient has caring responsibilities to vulnerable adults or to children, and the person is neglecting them. So this is risk to others. Risk to self, including suicide, including self-harm, or neglect. Neglect is a very wide term, including neglecting the surrounding environment, neglecting self-hygiene, neglecting mental health, risk of harm from others, including abuse abuse to the patient by other people, discrimination toward the patient by other people, or exploitation. So risk to self, there are some factors that suggesting high suicide intent, especially if the act is carried out in isolation, act time, so no intervention it can stop it. Preparations made in anticipation of this, like writing down a will or leaving goodbye notes. Precautions taken to avoid discovery. and factors like previous attempts, personality disorders, alcohol or drug misuse, previous psychiatric assessment, unemployment, low social class, criminal records, history of violence, age ranging from 25 to mid 50s, being single, not in a relationship. So all these are factors that can increase the possibility of the risk of repeating the attempt suicide. Um, so there is a risk of suicide and there is risk of deliberate self-harm. Some people may do a deliberate self-harm just for hope of accidental death or to obtain relief or to seek change in behavior from others or to show dispersion to others or to get help as a cry of help. And we will go in more details about the assessment of risk in other situations, with other disorders. So we will move to formulation. So after we do the history taking, after we do the mental state examination and assessing the risk, we will then go to formulation, which is the most important part of the psychiatric assessment. It is when we have to sit down and think about and study and analyze the data that we managed to collect. It is like an exercise in clinical reasoning that help clinicians to think clearly about diagnosis, etiology, and treatment. So we try to look into 5 P's. Presenting problem. What are the presenting problem? What are the difficulties that the patient is coming with? Is it related to mood? Is it related to behaviors? Is it related to feelings? Is it related to behaviors? And the expand of these issues. The secondly, we will ask ourselves about the predisposing factors. Why did this happen? And this is why we have been asking about all these questions in the history about the background and early life events. So predisposing factors are the adverses that happened in the past, and it did not extend to the future. It's happened and it's over, like childhood experiences, childhood trauma. So
كمل حضرتك. continue.
like childhood trauma in the past, and it's now over, but still have repercussions on the patient mental health. Precipitating factors, it's like why now? What happened recently that precipitate this decline in mental health and function? Perpetuating factors are, or the question of what keeps it going, what factors are maintaining the problem that the patient came with. So perpetuating factors is usually are something happening over a long period of time and it's still there. And protective factors, what helps the patient, what strengths, what resources are available, what resilience that can help patients to manage the issue in the future. So then we will come to formulating the 5 P's in like a short, small table where we put the presenting symptoms, predisposing factors, perpetuating, precipitating, protective factors, it can be helpful and useful to divide it into biological, psychological, and social, because based on this table, we will formulate our treatment plan. This table, we will summarize the problem that disturb the patient and the carers and the community, um, and it will be in front of our eyes. We will put our plan based on this table, and when we do the follow up, when the patient comes after, for follow up to assess the plan, we will go back to this table and see how successful the treatment plan managed the patient symptoms. Like, for example, the case that we brought today, when we so the basic informations and the presenting complaint, we came out with from it with by the fact that there is presenting symptoms of psychosis, psychotic-like symptoms beside an anxiety, and also socially he is isolating himself. I should add it also neglecting self-hygiene, biological. We learned that the protective factor is care from his mother. So uh, after we read the history present complaint, then we learned that there is another perpetuating factor for the disorder, which is not sleeping regularly. After we read the past psychiatric and medical history, we learned that I made some change here to add untreated hyperthyroidism and as a precipitating factor, loss of grandmother, recent loss of grandmother. As regard alcohol, data from alcohol and illicit substance history and family history, we added few information that there is alcohol and cannabis misuse as perpetuating factor. There is ongoing alcohol and cannabis misuse. Going through the personal history, will made it that there is unresolved childhood trauma. I made a little change in the personal history here just to demonstrate that as a predisposing factor, there is unresolved childhood trauma. Forensic history and premorbid personality came out with that protective factor that he has independent premorbid personality, which is a protective psychological factor for the patient. So so now, after we did this psychiatric history taking, mental state examination, risk assessment, we came out with this table of formulation of the problem and the predisposing factors, the perpetuating factors, the precipitating factors, and protective factors. And then we have to sit down and discuss with our team, with the patient, with the carer, how we can formulate the treatment plan based on this table. It's important to know that predisposing factors, we cannot do anything about it. It just happened unfortunately happened to the patient. But it alarms us that it can be still having repercussions during adulthood, and it needs intervention. So how we formulate the plan to our aim when we formulate a plan is to address all these concerns, all these factors. Provisional diagnosis, we based on the assessment, we decide about the disorder. We try our best to match the disorder with the international classification of ICD-10 or ICD-11, which is recently released by the WHO, and or the American classification, the DSM-5. And again, don't worry if you could not make your mind after one review. It can happen that you come with one review, you come out with 2, 3 provisional diagnosis, and which can later on be finalized with the repeated follow-ups and observation of the patient. A treatment plan is again a biopsychosocial model. The treatment plan is we are trying to answer a few questions. Where are you going to treat the patient? This depends on the risk assessment you did. Who, it's important to include, like, to be specific, like who does what to the patient, each part of the treatment plan should be very clear that who will be delivering this part and to the patient, so you can follow it up. The treatment plan has to be a holistic approach, including biological necessary investigations required to the patient, initial drug treatment and monitoring. It has to cover social needs of the patient, psychological needs, and the most important thing is the follow-up. I brought this diagram. It is called it's called, I think, it's Plan, Do, Study, Act. It's from our colleagues in business. So basically, when you put a plan, when you put a treatment plan, it's expected that you will put it in place, you will do the plan, and then you will bring it back to assess, to analyze it for in a follow-up, and then you will find that some of the aspects of your plan worked, so other aspects didn't work. So you'll have to reformulate the plan again, and then allow a period of follow-up and review the patient. The thing is, it is a cycle. It's not one-off process. It is a cycle that you keep on performing and assessing and changing, and this is how we usually plan. These are the references that I used, and thank you very much.
Thank you, Dr. Mustafa. Very holistic lecture about assessment. It is very good. Thank you, Dr. Mustafa.
Thank you.
جزيلا دكتور مصطفى. أنا كنت بقترح إن احنا نحول المحاضرة أو إلى الحاجات اللي حضرتك اتكلمتي فيها إلى شيت، سايكاتريك شيت، هم يملوه في كل مرة بيعملوا كيس برزنتيشن عشان نتأكد إن هم ملوا كل النقاط، فيبقى مخهم الأوتوماتيك بتاعهم ما بيفوتش جزء وياخد جزء. يعني حاجة يبقى ده الحاجة المتعارف عليها عنده، ان اي كيس برزنتيشن هيعملوها لازم يكونوا بيملوا الشيت اللي فيه كل الداتا اللي حضرتك قلت عليها.
تمام. ده حقيقة، واعتقد ان هم اكيد يعني
عندهم حاجة
شيت موجود. هو بصراحة يعني انا لما انا يعني لما انا جيت انجلترا اكتر حاجه عجبتني واكتر حاجه جذبت انتباهي واللي هي يعني ازاي ان هم بيفوكس على الفورميوليشن. يعني في ساعات الواحد من كتر المعلومات والداتا في حاجات بتبقى ميست من الشخص. فقصة الجدول أو الفورميوليشن دوت بيخلي كل المعلومات الكتيرة قوي دي اللي موجودة في الهيستوري وفي الاكزامينيشن وفي الريسك اسسمنت موجودة قدامك على جدول. وانت يعني بتحاسب لما بتحصل حاجة غلط، بتحاسب based on عملت ايه في الحاجات دي. يعني مثلا العيان بلغك ان هو كان عنده childhood trauma، آه وانت مثلا كتبت له دواء، طب انت عملت له يعني انت ريفيرد سايكولوجيكال، عملت له سايكولوجيكال تريتمنت. هو طبعا في النهايه احنا بنوفر، يعني بنعرض، والبيشنت هو اللي بيحدد وبيقرر اذا كان يحب يبروسيد ولا لا. فكانت القصه بتاعت وجود دي السمري اللي بيحدد شغلنا مع الحالة من أول ما بنستلمها لغاية لما يعني تبقى discharged من الكير. دي اللي أكتر حاجة لفتت انتباهي. لكن غالبية الشيت تيكينج والمنتال ستيت اكزامينيشن والاذر اسبيكتس بتاعت السايكاتريك اسسمنت هي نفس اللي موجودة في مصر، وأنا كنت برضو اشتغلت شوية في السعودية، فهي برضو هي نفس الموجودة في بلادنا يعني.
يس.
ايوه، بس للاسف انا لما بيبعتوا لي حالات وبيعملوا شيت ما بيبقاش بالشكل ده خالص يعني. فاعتقد ان
تمام.
الجزئيه دي ممكن تكون لسه
اه
مش واضحه
تمام.
عندهم هم في الغسل.
تمام. ممكن نعملها ممكن نعملها إن شاء الله، ونعملها بشكل بيساعد شوية إن يكون يعني إن إحنا يعني نخلي الاعتماد على الذاكرة أقل، يعني تبقى الأسئلة كلها قدام البراكتيشنر، بحيث إنه يعني إنه بس يبقى تفكروا كده، اسأل على كذا، اسأل على كذا، لو في مثلا delusions طب اسأل على اعمل لها complete analysis بالأسئلة ديت يعني.
نعم.
اعتقد بالظبط علشان ما يتوهوش
تمام.
في السوسايتي. تمام.
نعم. أنا بتشكر حضرتك يا دكتور مصطفى، الله يعطيك العافية.
الله يكرمك، الله يعطيك
يعني
العافية.
بصراحة يعني المحاضرة دي شيقة تمام، وأنا برضو بضم صوتي للدكتورة رباب، إنه حضرتك تنزل بعد إذنك، يعني إنه المحاضرة على اللي هو المجموعة على الجروب، تمام أوكي، علشان اللي هم الأطباء المقيمين لما يحضروا إن شاء الله اللي هو الكلينيكال كيس المرة الجاية، تمام أوكي، تكون بنفس النظام وبنفس الترتيب، علشان طبعا في النهاية يكون طبعا يعني استفيدوا ان شاء الله. وانا بتشكر حضرتك كثير جدا طبعا، والدكتور احمد والدكتوره سحر وجميع الزملاء، انا
الله
بشكركم جدا.
يكرمك.
ربنا يبارك في حضرتك، ربنا
ربنا يحفظكم ويبارك فيكم يا
يا
رب.
يا رب.
يحفظكم جميعا.
الله يكرمك.
وسامحونا على اللي هو
لا
الانترنت.
خالص، ده
لا
انتوا اللي
خالص،
سامحونا، ده
لا
انتوا اللي
احنا
سامحونا
مقدرين
والله.
طبعا، احنا مقدرين،
الله يسلمكم يا رب، ان شاء الله يا
مقدرين
رب.
ومتوقعين ربنا يسلمكم ويحفظكم.
يا رب، وان شاء الله يا رب بتيجي الظروف ان شاء الله احسن، وبنشوفكم ان شاء الله يعني من وش لوش، يعني زي ما بيقولوا يعني.
ان شاء الله باذن
الله.
الله، ان شاء الله.
بإذن
ان
الله إن
شاء
شاء
الله يا
الله.
رب، ان شاء الله. انا بتشكر حضراتكم جميعا.
ربنا يبارك في حضرتك.
شكرا جزيلا، شكرا جزيلا.
شكرا شكرا.
تمام، خلاص ان شاء الله.
مع الف سلامه.
تمام،
الف
بألف
سلامه.
سلامة. بألف
مع
سلامة.
السلامة.
مع السلامة، مع السلامة.
السلام عليكم. آه، طيب
طيب احنا الاسبوع الجاي انا ان شاء الله ممكن ارتب ان انا اعمل الشيت دوت واحطه على الجروب الواتساب
تمام.
باذن الله.
تمام. او ممكن يبقى حتى جوجل بقى، انا بقى او هم يحطوه بقى على جوجل درايف عندهم.
ان شاء الله.
ان شاء الله.
تمام، خلاص ان شاء الله. احنا كده محتاجين نبقى بنجتمع بس، او يعني نشوف بقى ننسق المرة الجاية هيبقى في ايه ان شاء الله. هما غالبا ان شاء الله تبقى الكيس برزنتيشن اللي هم كانوا هيعملوها، ونشوف ايه اللي هيتعمل بقى من الكوريكولم، يعني نكمل الكوريكولم ازاي ان شاء الله.
ان
السلام
شاء
عليكم
الله.
ورحمة الله.
حضرتك عايز تقول حاجة يا دكتور احمد؟
انا يعني ما شاء الله، ربنا يبارك في حضراتكم ويجزيكم كل خير. ال ال الشغل كويس جدا، والفكره طبعا المحاضره رائعه دكتور مصطفى، ربنا يبارك في عليك يا رب.
الله
يعني
يك
حاجه
الله يكرم
انا
حضرتك،
كنت
الله
مختلف
يكرم.
عنها، مش علاقه بالطب النفسي، ويعني كنت مستمتع جدا جدا. ربنا يبارك في سيادتك يا رب ان شاء الله باذن الله.
الله يبارك في سيادتك.
المكسب الكبير اللي احنا حققناه النهارده ان احنا بدانا نحتك مع الناس، بدانا يعني ايه، نتعرف ايه اللي موجود. I'm sure ان شاء الله باذن الله مره بعد مره، خاصه ان انتظام الميتنج كل اسبوع ده على فكره معدل عالي جدا ومعدل ممتاز. يعني في اغلب التخصصات التانيه بيبقى الميتنج يا اما شهري يا اما نصف شهري، فكونه كل اسبوع ده هيدي فرصه اكبر باذن الله ان احنا يعني نتعمق اكتر معاهم ونعرف احتياجاتهم اكتر وباذن الله ان شاء الله يكون على ايديكم في يعني ايه تقدم ملموس في النقطه دي ان شاء الله باذن الله. وربنا يبارك في حضراتكم ويجزيكم كل خير.
هو دكتور
الله
ياسر
يكرم.
حضرتك معانا لسه مش كده؟
أسامك يا دكتورة سحر. نعم.
انا بقول هل انتوا بالنسبه للمحاضرات، يعني مش احنا هنعمل كيس برزنتيشن، بس بالنسبه للمحاضرات هل في مثلا عندكم اولويه لحاجات معينه محتاجين نغطيها الاول؟ دي حاجه. الحاجه التانية بالنسبه
نعم.
للجورنال كلاب، هل
مم.
يعني عندكم preferences للارتكلز او الحاجات اللي احنا ممكن نشتغل عليها، ولا احنا نقترح حاجات و... و... والزملاء يبتدوا يشتغلوا عليها؟ يعني زي ان انا النهارده مثلا كنت جايبه حاجه عن استادي عن غزه، عن الناس في
أوكي.
غزه. فهل
تمام.
يعني محتاجين بس نبقى بننسق ده مع بعض، بحيث انه احنا ما نبقاش ماشيين من دماغنا، ولكن احنا اهم حاجة انه ايه احتياجاتكم، وان احنا نفيد انتوا احتياجاتكم.
أوكي تمام. بالنسبة دكتورة سحر يعني لأسئلتك، تمام. بالنسبة للمحاضرات اللي هي طبعا المحاضرات اللي هي الكومون، تمام، سواء اللي هو السكيزوفرينيا، سواء البايبولار، تمام، اوكي، سواء حتى اللي هو الامرجنسي في السايكاتري، مثلا زي السوسايدال مثلا ايديشن او حتى سوسايدال اتم، تمام. دي طبعا كلها مواضيع بصراحه مهمه طبعا، اوكي. طبعا دي عاوزين نركز عليها، بالاضافه طبعا البي تي اس دي، بالاضافه طبعا اللي هو السايكوثيرابي، لانه بصراحه السايكوثيرابي برضه بده يعني ايش، يعني ندعم وننشط ونطور طبعا ايش اللي هم الاطباء المقيمين عندنا، تمام. انه ازاي مثلا مثلا يتعاملوا مثلا مع الحاله دي، مثلا سي بي تي او حتى دي بي تي، او حتى مثلا انتر بيرسونال سايكوثيرابي، او حتى مثلا المنتاليزيشنز وهلم جرى، وحتى الجروب ثيرابي او الفاميلي ثيرابي وهكذا، اوكي تمام. هذه بالنسبه للمحاضرات. بالنسبه للجورنال كلاب، تمام، الجورنال كلاب دكتوره يعني هيكون ان شاء الله بيناتنا تنسيق باذن الله، تمام. برضه احنا ما بنستغنيش عن حضرتك يعني طبعا، معلوماتك او حتى اختياراتك للجورنال كلاب طبعا تكون ان شاء الله باذن الله موفقه، تمام، اوكي، وان شاء الله يكون فيها استفاده بالنسبه لنا وحتى لكل زملاتنا ولكل اطبائنا ان شاء الله.
يا الله بإذن الله. تمام، خلاص إن شاء الله بإذن الله. خير. في أي إضافة حضراتكم حابين تضيفوها؟
هو أنا بفكر يعني مثلا، طب الأسبوع الجاي هيبقى فيه محاضرة، يعني هنحتاج
اوكي.
نحضر محاضرة.
دكتور مصطفى، انا دكتور عبد الله لما حكى معايا، تمام، اوكي، على الموبايل، حكى لي هم عاوزين يظبطوا اللي هو الانترنت، تمام، اوكي. بمجرد ان شاء الله انه يجهز عندهم الانترنت، ان شاء الله هنتواصل على المجموعه عشان نحدد ميعاد او موعد جديد ان شاء الله، ايه، لانطلاق المحاضرات واللي هو الكلينيكال برزنتيشنز باذن الله. ان
تمام، خلاص إن
شاء الله يعني هنكون على تواصل باذن الله
على
ان شاء الله.
تواصل. تمام تمام.
بإذن الله إن شاء
إن شاء
الله،
الله،
ان
إن
شاء
شاء
خلاص
الله.
إن شاء الله. ماشي يا فندم. ماشي، شكرا يا دكتور ياسر، شكرا دكتور رباب، شكرا دكتور مصطفى، شكرا دكتور أحمد. وربنا كده يتقبل ويبارك إن شاء الله.
الله. يا رب.
الله
يا رب.
شكرا شكرا.
تحياتنا لكم جميعا.
ربنا يبارك
الله
فيك.
يكرمك، الله
يا
يعزك.
رب. بالنسبه للدكتوره رباب، انا ان شاء الله بحكي مع الدكتوره مي عبد العال، اللي هي طبعا تتواصل مع حضرتك بخصوص اللي هو طبعا تحويل الحالات لسيكوثيرابي.
تمام تمام إن شاء الله. تمام
ان
كويس
شاء
أوي.
الله.
شكرا جدا.
ثانك يو فيري ماتش. ثانك يو.
شكرا بقى. السلام عليكم.
مع الف سلامه.
شكرا شكرا.
مع الف سلامه.